Well, good day, everybody. My name is Vasili Lendel. I'm a cardiologist here at Arkansas Heart Hospital, and I'm delighted to present a case which we have done a month ago. 79-year-old man with the typical comorbidities of PAF and hypertension, diabetes, chronic kidney disease, presented with refractory claudication, failed medical therapy, physical therapy. Has a single vessel round, which normally you would argue whether he needs to have anything done. But the patient was significantly symptomatic, and the actually demanded action. And angiogram demonstrated severely calcified tibial peroneal trunk. AT patent, however, terminates, and very poor flow in distally. Our plan is to cross proximally advanced wire distally, treat the posterior tibial artery with a thoracotomy or shockwave balloon. Vessel is heavily calcified. The problem was that by the time we got to the distal cap of the vessel, I could not penetrate distal cap with every wire I had in my armamentarium. We tried gear, we tried a starter, and I could not penetrate distal cap. Therefore, we decided to treat the vessel with Javelin. The idea was to treat all the way to proximal to third, get to the distal cap, get across, and finish the case. Well, unfortunately, as we got to distal cap, everything treated, but I could not still penetrate the distal cap, neither with Javelin, and the wire did not, there was not enough support on my antegrade wire. Therefore, decision was made to obtain retrograde access, the lateral plantar arch. We're able to externalize the wire, create a rail, and in that case, it allows us to penetrate proximal distal cap and treat the rest of the remaining posterior tibial artery using Javelin. Then we're able to advance and treat the artery using shockwave balloon. You could see here that we used a 2.5 millimeter shockwave to treat posterior tibial artery and finish with a long 3 millimeter Armada balloon. And the results were good. He had a good, excellent outflow. Patient was very happy with his symptoms afterwards. Case was safe. There's no complications. Fairly easy to cross and allow us to the retrograde access allow us to create a monorail system to advance the Javelin catheter antegrade and subsequently advance the rest of the balloons. The reason I used Javelin because I thought the lesion was more than 200 centimeters long, 200 millimeters long lesion. And therefore, as we could not barely advance anything, I did not think that we could advance or cross lesions with stents. No stents with the cross lesions with balloons. Javelin has made a marked difference here and allow us to treat the vessel properly using shockwave and a Javelin used in a very long, heavily calcified lesions, not only for above the knee vessels, but specifically below the knee with heavily calcified arteries. It would have made the case 3 hours longer, and we would have struggled to advance any type of equipment. Orbital thoracotomy has been historically used in heavily calcified lesions, but the problem is the delivery of the catheter, and often the hydrophilic wires would advance distally, and you struggle for a long time to advance a rotor wire. Cases are typically very, very long and very time and labor intensive. So Javelin in those cases will allow us to at least save 50% of time. So in balloon angioplasty, you can argue whether shockwave balloon adds additional value, but at least It depends on the situation, of course, but I would follow Javelin with balloon angioplasty with appropriate size balloon. Long sheath, your support needs to be upfront thought, and the better the support integrate with long, appropriately sized sheath is a key, and also good wire support. You can always ration them in, exactly. You have to ration them in, and really focus on the lesions which require with most of the calcium. But you have to think upfront how many pulses you're going to deliver in every segment of the vessel.